Good morning. The hearing will come to order. Let me just say a thank you to all of the members for joining us today. Given the virtual environment, I'm going to ask unanimous consent that the chair be authorized to declare a recess at any time to address technical difficulties that might arise with such remote proceedings. Unanimous consent, so ordered. I'll proceed. Before we start the hearing, I've been asked to do a few housekeeping points as well. We're holding the hearing virtually. It's in compliance with the regulations for committee proceedings pursuant to House Resolution 965. Consistent with the regulations, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. We are not permitted to unmute members unless they explicitly request assistance. If I notice that you have not unmuted yourself, I will ask you if you would like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. They will not unmute you under any other conditions. To ensure that committee members are given the opportunity to question each witness, we will have 2 rounds of questions after witness testimony has concluded. Each member of the committee will be given 5 minutes to question the witnesses. We will proceed in the order of committee seniority, alternating between the majority and minority. Finally, for the committee, we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings or markups, including documents to be inserted in the record by unanimous consent, amendments, motions, and other unanimous consent requests, and so on. The email address is houseappropriations.submissions@mail.house.gov. That information has been provided to your staff, so not to worry if you didn't get it down. Let me just thank you for your patience and your understanding as we navigate the technology and the platform. I think I get more nervous about all the instructions that we have to follow as much as the content or of any of our hearings. I want to make sure it's right and that everyone gets their opportunity to be able to communicate and to participate. So are there any questions? If not, let's go. As I said, the subcommittee will come to order. I want good morning to all. Let me welcome our witnesses today. We are going to examine the impact on women seeking an abortion but are denied because of an inability to pay. Roe versus Wade is the law of the land, yet for too long, some women in this country have been denied their right to an abortion. The Hyde Amendment is a discriminatory policy, and for more than 40 years, it has been routinely extended every year as a legislative rider. But the time has come in this current moment to reckon with the norm, with the status quo, view it through the lens of how it impacts communities of color. Connecticut's Medicaid program has covered abortion services using state funding since 1986, based on a Connecticut Supreme Court decision. To date, that decision has never been appealed. 8 other states providing funding for abortion pursuant to a court order, while 7 fund abortions voluntarily, all using state dollars. However, 33 states and the District of Columbia deny state funding to women seeking access to abortion. As a result, the millions of economically insecure women in these states are hostage to their geography. For the women in these states covered by Medicaid, The Hyde Amendment has a tremendous impact on their economic, mental, and physical well-being. We know that without insurance coverage of abortion, a legal healthcare procedure, they face costs of more than $500 on average, but can exceed $1,000 depending on where they live and the type of abortion. This does not include out-of-pocket expenses like childcare, time off from work, and travel. These costs are prohibitive for too many women. One study found even in a state like California that uses its own funds to provide coverage because these providers are typically concentrated in urban areas, rural patients have had to travel more than 50 miles to obtain an abortion. A study published in the January 2020 edition of the American Journal of Public Health found that more than 75% of requests to an online telemedicine abortion service hailed from states with hostile restrictions, including the Hyde Amendment, with cost being the most common barrier. The landmark Turnaway study, led by Dr. Diana Green Foster, a demographer at the University of California, San Francisco, who evaluates the effectiveness of family planning policies and the effect of unintended pregnancy on women's lives, found that women's health and well-being suffer serious consequences after being denied a wanted abortion. This was the largest study to examine women's experiences with abortion and unwanted pregnancy in the United States, with the goal to understand mental health, physical health, and socioeconomic consequences of receiving an abortion compared to carrying an unwanted pregnancy to term. And it found the following. For women denied an abortion despite wanting one because it was the right decision for themselves and their families, women being forced to carry an unwanted pregnancy to term are 4 times more likely to live below the federal poverty level. Women are more likely to experience serious complications at the end of their unwanted pregnancy, including eclampsia and death, contributing to the maternal mortality rate in this country that should be embarrassing and unacceptable to everyone participating today. These women denied an abortion are more likely to stay with an abusive partner. These women who were denied a safe and legal medical procedure are more likely to suffer anxiety, loss of self-esteem, and less likely to have aspirational plans for their future after being denied an abortion. Finally, the Turnaway study found that being denied has serious implications for the existing children in the family. And who was being harmed the most by the Hyde Amendment and being forced to continue unwanted pregnancies? More than half, 58%, of the women affected by the Hyde Amendment are women of color. Almost 1/3, 31%, are Black, 27% Latina, nearly 1/5, 19%, Asian Americans, and Pacific Islander women, as well as Indigenous women, also covered by Medicaid. While the Labor HHS education bill has carried the Hyde Amendment every year since 1976, this is the last year. The inequities in our country's healthcare system that have been exposed by the COVID-19 pandemic all further expose the impact of the Hyde Amendment. All of these issues deny the humanity of people of color and their ability to do well for their families and their communities. Now is the time to empower all women to be able to make deeply personal life decisions without politicians inserting themselves into the doctor's office, to ensure that regardless of geography, all women are treated fairly and equally, and to improve women's health. I thank everyone for being here today and for lending your expertise. And before I turn to our witnesses, however, let me turn to my friend, the ranking member of the subcommittee, Ranking Member Tom Cole, for any remarks that he would like to make. My colleague, Congressman Cole.
Well, thank you very much, Madam Chair. Let me begin with a few personal remarks before I get to my prepared remarks, I want to thank the distinguished chairwoman of the full committee for joining us as she so frequently does. Today, this may well be her last appearance with our committee as our full chairman, and we all admire her as our leader and appreciate her as a friend, and know that she's had a special place in her heart for the Labor H subcommittee throughout her tenure. And we do notice that, Madam Chair, in our allocation, and so we're grateful. But I would also be remiss if I didn't start by congratulating you on your ascension to the position of full chair of the Appropriations Committee in the next Congress. You know, the great British statesman Benjamin Disraeli, when he finally became prime minister after a long career, told his colleagues that he had gotten to the top of the greasy pole. Well, you've gotten to the top of the greasy pole of the Appropriations Committee. And we should all remember that's quite an achievement. Not very many appropriators, and we have a distinguished subcommittee here, and I think we have a very distinguished committee, ever reached the level that you've reached. You're the second woman to ever do that after our trailblazing chairman, Nita Lowey. And I think this is actually, while you'll forgive me, I would prefer a Republican majority to a Democratic majority. But if we're going to have a Democratic majority, we are, I couldn't think of a better person to chair this subcommittee, to chair the full committee. And I say that for a couple of reasons. First, I've had the opportunity to work with you as both chairman and ranking member. I'm very proud when I was chairman on 4 occasions, when we finally got to the final negotiation with our colleagues in the Senate, we were able to vote together for the passage of the bill after we had made the appropriate compromises. I was very proud last year to be able to vote with you on your very first bill. And as I know members of this committee know, you and I are working with our colleagues, Senator Blunt and Senator Murray, right now in the hope that we can achieve a bill that all of us can once again vote for in a bipartisan manner and move ahead. So while we belong in different parties, and we certainly disagree pretty sharply on some issues, you've always been someone who has been willing to work together and find common ground, and I know you'll continue that characteristic in your role as the full committee chair. The second reason why I'm happy is I really do know who your favorite subcommittee is going to be. So I think that's good news for all of us on this subcommittee, and I don't presume to know what role you'll take as the chairman of the full committee. And but again, I know we will always be close to your heart and in your thoughts as you make the decisions for the full committee. So thank you for that. And again, Madam Chair and soon to be chair of the full committee, congratulations on a well-earned honor. And to my Democratic colleagues, I congratulate you on your good judgment. You had several excellent candidates, I know, but you picked, in my view, the absolute best person for the institution and certainly for our committee. I could not be more pleased. Madam Chair, you've chosen on this hearing to pick a pretty contentious topic for us to deal with, and an important topic, but a topic that not likely to see much change of position on either side. And that, of course, is your prerogative, and I respect that. But I'm going to be fairly forceful in my statements because just as you feel strongly about this issue, so do I, so do many of the colleagues on my side of the aisle. So I'm proud to have the opportunity today to publicly state my unwavering support for the Hyde Amendment. This language, named for its original sponsor, the late Congressman Henry Hyde, prevents federal taxpayer dollars in the Labor, Health, and Human Services Appropriations Bill and the federal contribution to the Medicaid program from being used to pay for abortions, with limited exceptions to save the life of the mother or in very difficult circumstances of a pregnancy that result from an act of rape or incest. It's estimated that this provision has saved the lives of over 2 million people since it was first adopted in 1976, most of them people of color. Before the enactment of this provision, the federal Medicaid program was paying for nearly 300,000 abortions annually. The Hyde Amendment has been included in some form in every appropriations bill for almost 45 years. It's enjoyed bipartisan support every year, regardless of which party held the White House, the House, or the Senate. During the Obama administration, President Obama maintained the Hyde Amendment in each one of his budget proposals. As recently as last year, then Vice President Joe Biden expressed his support for the Hyde Amendment. Sadly, he seems to have abandoned that long-held position just this year. The majority of the American people, however, including the majority of low-income women, also support the Hyde Amendment. Even most people who identify themselves as pro-choice on abortion issues don't want their taxpayer dollars to be used to pay for someone else's abortion. The Hyde Amendment protects the conscience rights of the great majority of Americans who are opposed to publicly funded abortion for religious, moral, or simply fiscal reasons. Hyde leaves the people and the legislatures of all 50 states free to provide state funds for abortion if they wish. In fact, most states have voluntarily decided to follow Hyde's policy, sometimes by a direct vote of the people. Rescinding the Hyde Amendment would impose a pro-abortion funding policy on states that have decided against it. Hyde allows states to choose whether or not to fund elective abortions with taxpayer dollars, and the people and elected representatives of 34 states have voluntarily chosen not to do so. Without the amendment, abortion would likely become just another basic service that all states must fund as a requirement to participate in the Medicaid program. Finally, I want to address head-on what I believe is perhaps the most insidious falsehood about the Hyde Amendment, and that is that free abortions are necessary to help low-income women and women of color succeed in this country. Most Americans who support the Hyde Amendment believe that an abortion is the intentional destruction of innocent human life. It's not health care for women. Refusing to cooperate with or pay for the destruction of someone's child is not an action against that person, but for them and their community. Americans should want life for poor women, women of color, and all women and their children. As stewards of the federal tax dollar, we cannot and should not participate in encouraging a choice for taxpayer-subsidized abortion. Women of color and all women deserve resources such as prenatal care, well baby care, and more child care options and support to enable them to fully care for their children. These are policies I've supported as chair of this subcommittee and as ranking member, and will continue to support as long as I'm in public office. Put simply, abortion capitulates to despair and says there's no hope for the woman as a mother or for the child. Supporters of abortion should also question whether the promotion of abortion is itself structurally racist, since it disproportionately affects people of color and substantially reduces births of women of color to a much greater extent than births of white women. For example, Planned Parenthood, which operates the largest chain of abortion clinics in the United States, disproportionately locates them in or within close walking distance of minority neighborhoods. Finally, Black women are disproportionately represented in the Medicaid population, and their abortion rate is over 3 times that of white women. Ending the Hyde Amendment and providing state-funded abortion to low-income women will mean more Black lives lost, especially at this time when our country is facing some very difficult and appropriate conversations about how groups have been treated in the past and continue to be treated today. We need to be advancing public policies that support women of color and their families, and not policies that end the lives of the unborn. Let me make a final point, Madam Chair, if I may, and that's political reality. I don't think opinions on this issue are likely to change. And should the Hyde Amendment be removed from the Labor, Health and Human Services Appropriation Bill, I think there would be very little Republican support for it in either the House or the Senate. And particularly in the Senate, it looks, no matter what happens in Georgia, as if the filibuster rule is likely to be maintained, given the statements of Democratic senators. So I see this as an effort that is not likely to bear fruit in the next Congress. Although, again, I respect your prerogative as chairman, certainly, to hold a hearing on whatever matter that you think is appropriate. And before I close, I want to especially thank our witness, Christina Bennett, for speaking to us today. Christina has a powerful story to tell, and she has a voice for many who have no voice. Christina, I look forward to our discussion today, and thank you for coming before us. With that, Madam Chair, again, congratulations to you. for becoming our chair. For our current chair, thank you for being with us once again. We've always been your favorite, just as we will be the next chairman's favorite. And I yield back the balance of my time.
Thank you so much to the ranking member. And in fact, it's I think you hit a true note in, knowing where my love for this subcommittee, as it was for my predecessor here. So, and I think for that was true of David Obey as well, and a while back, et cetera. So, but let me just say thank you to you. And while you pointed out that we do disagree, and we disagree on the content of today's hearing, let me just say I just treasure, and I mean this very sincerely, our friendship as we go forward, because it is so important, especially now in these times, to look at how we are going to help this country survive a pandemic, the largest, the biggest economic and healthcare crisis that we have faced in a generation. And our ability to do that depends not on how much we disagree, but how much we can agree to move forward on. And I think that we have that great opportunity within this subcommittee and with the Appropriations Committee writ large. And it's the greatest honor of my career to have been elected to serve in this position. And as we all know, when your peers put their faith and their trust and their confidence in you, there is no higher accolade. The people who know you best, who watch you under good circumstances and bad circumstances, but they concluded this, and I could not be happier. And I thank you for your very, very beautiful remarks. So with that, I want to extend to our witnesses this morning a very, very warm welcome. We have Dr. Herminia Palacio, who's president and CEO of the Guttmacher Institute and our deputy mayor for Health and Human Services for the city of New York. Dr. Jamila Perit, president and CEO of Physicians for Reproductive Health and a fellowship-trained, board-certified OBGYN practicing in Maryland, Virginia, and the District of Columbia. Ms. Amanda Beatrice Williams, executive director of the Lilith Fund, and Ms. Christina Bennett, communications director of the Family Institute of Connecticut. We will hear testimony momentarily, but first, there has been a significant interest from advocacy groups to submit letters or statements for the official hearing record. I have spoken with Ranking Member Cole, and we've agreed to leave the hearing record open for 24 hours to accommodate this interest in submitting letters or statements for the record. And before we proceed with our witnesses, Congressman Cole, you aptly noted that today is our dear friend Nita Lowey's, the chair of the Full Appropriations Committee, what will be her last appropriations hearing. And for me personally, I have had the unbelievable value and closeness of her friendship over these years. Along with Speaker Pelosi, Nita Lowey and I have always been plotting ways to advance women's health, and a lot of progress we've made for women through federal spending bills started with a side conversation. Congresswoman Lowey's legislative director, Dana Acton, recently found a letter sent by Congresswoman Lowey, Congresswoman at the time, Pelosi, and myself to the then President Bill Clinton, from February 1st, 1994, urging him to submit a budget that is completely unencumbered by the Hyde Amendment. This letter came 7 months after a vote to repeal the Hyde Amendment failed, in which Congresswoman Lowey is quoted in the Baltimore Sun saying, and I quote, "It certainly wasn't a great day. In fact, it was most nasty and unpleasant," end quote. The fight for reproductive rights in the Congress has not been without its ups and downs, victories and defeats. But Congresswoman Nita Lowey has never stopped working to ensure that women have access to reproductive health care. She is responsible for saving the Title X family planning program that millions around the country rely on. In 1996, when the Republican budget eliminated it, Nita Lowey sprung into action. She created an ad hoc bipartisan whip team. She saw an attack on reproductive health and an attempt to deny access to the people who need it the most. She stood up, she acted, and she won. Congresswoman Lowey's leadership, her grit, her determination, and her ability to build a consensus across the aisle saved this critical program. And next year, when the Labor, Health, and Human Services Education Appropriations Bill for fiscal year 2022 was released without the Hyde Amendment, it will be in large part due to my dear friend, our dear friend, Congresswoman Nita Lowey. I am honored to have worked under the auspicious leadership of a path maker, path breaker, and a change maker. And I know that I have large shoes to fit next year beyond the critical work we have done together, which has been an unbelievable honor, Nita. Nita Lowey is more than a colleague or a friend. She is family. And I'd now like to turn it over to our distinguished chairwoman for any opening remarks that she may have. Congresswoman Nita Lowey.
Well, what can I say to my dear friend, the chair, Rosa DeLauro, and my dear friend, my good friend for so long, Ranking Member Tom Cole, for your work and your dedication to this subcommittee. It really is bittersweet that this will be my last hearing in Congress. Early in my career, I had the privilege of chairing the pro-choice caucus back when it was bipartisan. I've been fighting for reproductive rights and combating the Hyde Amendment for decades. In fact, as my dear friend Chair DeLauro referenced, my staff recently came across the letter from 1994 to then President Clinton, signed by my sisters on this subcommittee, Representative Rosa DeLauro, Nancy Pelosi, and myself, urging him to submit a budget completely unencumbered by restrictive Medicaid abortion language. That letter could be written today. Sadly, that's because the Hyde Amendment and other restrictions on access to reproductive health care continue to attack the dignity of low-income Americans. The Hyde Amendment has created two sets of rules, one for those with resources and one for those without. After more than 40 years, it continues to impose judgment and bully low-income women with a disproportionate impact on women of color. In this subcommittee, we have debated the issue of reproductive rights at length. We could all probably recite the speeches our friends on both sides of the aisle make at markups. But more often than not, we talk past each other. We don't talk about what federal policies mean for a woman sitting in a doctor's office in fear of the risk to her own health or financial security. We don't talk enough about how to help her, The truth is that women has been discriminated against by the laws of her country just because of her income. That this continues to happen in 2020, in my judgment, is a disgrace. Regardless of what we feel about the issue of abortion, it is well past time that we, as members of this great committee, discuss the harmful legacy of the Hyde Amendment. We should listen to the experts and understand the harms and real-life consequences imposed by this rider. It is my fervent wish that the next Congress will correct this historic inequity in women's health care and remove Hyde once and for all. It deserves to be in the dustbin of history with other policies that were designed to limit the rights of the powerless. I will be cheering you on. So before I close and say thank you, I just want to say that it is such a thrill for me to be turning over the head of appropriations to my dear friend, strong advocate, principal leader, Rosa DeLauro. I know she will continue to fight for the issues that we care about because not everyone may agree, but we feel we're on the right side of history. And I do want to say to my dear friend, Tom Cole, we've worked together a very, very long time. And although we may disagree on this issue and a couple of other issues, I have such respect for Tom Cole's intellect, his character, and his determination to fight for what is right. So, Tom, I do love you and I do appreciate your leadership. And for me, it's been an honor to serve on this committee with you and Rosa DeLauro. And I do wish you both, of course, first of all, good health, strong advocacy, and we'll all keep fighting for what we believe is right. That's what this is all about. So I expect that some of us differ on this issues, others differ on other issues, but we've all had for the past years, I've been here 32 years, I can't even believe it, Rosa and Tom, we all are determined to fight for what is right. So for me, I want to wish my dear friend as chair, Rosa DeLauro, and my dear friend Tom Cole, the ranking member, good luck, good health, Godspeed. Thank you for giving me the opportunity to say a few words. I love you both, and I love this committee.
You will always be a member of this committee, Anita, and you will always be in touch. I know you're not walking away. You're not going away, and we need your advice and counsel. So, with that, let me just move to our witnesses this morning. And again, I extend a very warm welcome to you, and we will proceed in this order: Dr. Herminio Palacio, Dr. Jamila Perrett, Ms. Amanda Beatrice Williams, and Ms. Christina Bennett. So, Dr. Palacio, please.
Thank you very much, Chair Lowey. Good morning, Chair DeLauro, Ranking Member Cole, and members of the subcommittee. I appreciate the opportunity to testify on this important issue. My name is Dr. Herminia Palacio. I'm the president and CEO of the Guttmacher Institute, a nonprofit research and policy organization committed to advancing sexual and reproductive health and rights in the United States and globally. Guttmacher has collected and analyzed U.S. abortion data for more than 50 years and has tracked state abortion policy since the early 1970s. I also bring 30 years of public health and healthcare experience, including 15 years practicing medicine in San Francisco during the height of the HIV/AIDS epidemic. My patients experienced firsthand how supportive or how oppressive federal and state policies could be with their respect to their sexual health, reproductive autonomy, and healthcare access. Today, I'll highlight 3 main points backed by science and evidence. First, abortion is a healthcare experience shared by many people. Abortion patients include people of every race, religion, political affiliation, and socioeconomic group, and the majority are already parents. 1 in 4 cisgender women in the United States will have an abortion in their lifetime. Likewise, trans men and gender nonconforming individuals require access to the full range of pregnancy-related care. Overall, 75% of abortion patients in the United States are low income, and the majority are people of color. Which brings me to my second point. The harmful burdens of the Hyde Amendment are intentionally and unjustly imposed on Black and Brown people and on people with low incomes. In other words, on people who've been historically marginalized. Across 34 states and the District of Columbia, the Hyde Amendment leaves 7 million women who are already struggling financially without abortion coverage. On average, an abortion at 10 weeks costs around $550, which could be somebody's entire rent payment, and the cost increases over time. Contrast that with the fact that even before the current recession, 37% of Americans said they would struggle to cover an emergency expense of $400 for any purpose. Because of the legacy of systemic racism in this country, Black and Brown women are disproportionately likely to be insured through Medicaid. 31% of Black women and 27% of Hispanic women aged 15 to 44 are enrolled in Medicaid, compared with 16% of white women. As our country undergoes a racial reckoning, I want to be very clear. The Hyde Amendment is a racist policy. My final point centers on the evidence demonstrating the serious and long-lasting consequences of withholding abortion coverage. Many people with low incomes experience delays in accessing abortion care because of the time and effort needed to pull together funds. People get caught in a cruel cycle in which delays associated with raising the money leads to additional costs and subsequent delays. A literature review conducted by Guttmacher concluded that among women with Medicaid coverage subject to the Hyde Amendment, 1 in 4 who seek an abortion are forced to continue the pregnancy. Forcing someone who wants an abortion to continue a pregnancy is not only a violation of their reproductive autonomy, it is tantamount to requiring them, against their wishes, to accept the risk of pregnancy and labor-related complications, including preeclampsia, infections, and death. The United States has the highest maternal mortality rate among developed countries, with a dramatic but preventable racial inequities. Black and Indigenous women's maternal mortality rates are 2 to 3 times that of white women. I ask you to reflect on these overlapping and perverse indignities. The Hyde Amendment disproportionately withholds abortion coverage from Black and Brown communities, a potential consequence of which is being forced to continue pregnancy in a system in which Black and Indigenous people are astonishingly more likely to die. Moreover, the risks of consequences do not end with a safe delivery. As the chairwoman pointed out, the Turnaway study by researchers at the University of California, San Francisco, found that women who don't attain a wanted abortion have 4 times the greater odds of subsequently living in poverty and 3 times greater odds of being unemployed. In addition, women experience intimate partner violence. Being forced to carry an unwanted pregnancy to term can delay separation from their partner, resulting in ongoing exposure to violence. In sum, the Hyde Amendment has been unjust and harmful from the very beginning. Congress, starting with this subcommittee, has both the opportunity and ethical imperative to lead toward reproductive justice, beginning with this first step of eliminating the Hyde Amendment. I thank you for this opportunity and look forward to answering your questions.
Dr. Parrott? I think you.
Good morning, and thank you, Chairwoman Lowey, Chairwoman Delario, Ranking Member Cole, and members of the subcommittee. I'm here today on behalf of the people I care for and the community I serve every day, people profoundly impacted by insurance coverage barriers like the Hyde Amendment. My name is Dr. Jamila Parrott. I'm a board-certified, fellowship-trained obstetrician and gynecologist. I'm here today to talk with you about my patients. Whether they're ready to build a family or already parenting or focused on their education or career, the patients I care for share something in common. They are all making thoughtful, sometimes difficult decisions about their health and well-being, and all deserve high-quality care. As the subcommittee is aware, annual appropriation bills include harmful bans on coverage for abortion care, including the Hyde Amendment. Hyde-like restrictions have also been added for groups including federal employees and people serving in the military. The Hyde Amendment is discriminatory. It disproportionately harms people of color, young people, and those living in rural areas. I'm not a legislator, but I am a doctor, and I take care of real people who are not able to get the care they need and deserve because of this discriminatory legislation. As was mentioned in the introduction, I live and provide care in the District of Columbia, which is prevented from covering abortion even with our own local revenue, unlike other states. As an OBGYN, I see what happens when women don't have access to services because they lack coverage and cannot afford to pay. Abortion care is no different. The Hyde Amendment denies my patients the ability to make decisions about their bodies and their pregnancies because of where they live and how much they make. More than 177,000 people in the district are federal employees. This is 7.56% of the federal workforce, and they too lack coverage for abortion. For those living paycheck to paycheck, the cost of reproductive health care and additional expenses like childcare, transportation, and time away from work can be insurmountable. They are placed in the untenable position of deciding whether to pay their bills or pulling together the resources to access the care that they need, or they may forego an abortion altogether and carry an unwanted pregnancy to term. This outcome is not insignificant. As you've heard, the Turnaway study that was mentioned previously identified serious consequences when people were denied the abortion care they were seeking. A greater likelihood of living in poverty, more likely to experience pregnancy complications, to stay tied to abusive partners, and to suffer mental health effects. Withholding coverage continues to perpetuate a two-tiered system of healthcare dictated by one's income, socioeconomic status, and zip code. In the 4 decades of the Hyde Amendment, we have seen worsening health inequality for Black, Indigenous, and other people of color in this country. Healthcare disparities manifested by a lack of accessible preventive care like contraception, preconception care, and other preventive health measures work to maintain these inequities for women of color, while rates for other communities continue to fall. For my entire career, the Hyde Amendment has been used to intentionally limit my ability to give patients the care that they need. I must be clear today in saying abortion is healthcare. Insurance coverage of abortion should be comparable to other essential health services, and abortion should not be singled out for exclusion or have additional burdens placed upon it. The American College of Obstetricians and Gynecologists, ACOG, has identified abortion as an essential health service that requires timely access to care. ACOG also recommends the elimination of abortion coverage restrictions to ensure that all people, regardless of socioeconomic status, have access to care. Many factors influence a person's need to have an abortion. These influences are valid, and people should be able to access this care without unjust policies creating insurmountable barriers. I took an oath to provide compassionate care. Coverage bans like the Hyde Amendment stand in the way. What I want us all to understand is that no one is making decisions in a vacuum. Our lives are intersectional. Our identities and experience factor into decisions around contraceptive use, pregnancy, and abortion. Organizers and advocates, reproductive justice leaders who are carrying this work forward every day know what I am telling you. Coverage restrictions like Hyde harm patients. Lawmakers have an opportunity today to take steps that are necessary to ensure all people are able to access the care that they need, regardless of where they live or how much money they make. I urge you to do so. My patients, and more importantly, our communities deserve it. Thank you for your time.
Thank you. Ms. Williams?
Yes, thank you. Good morning, Chairwoman DeLauro, Ranking Member Cole, and members of the committee. Thank you so much for having me before you today to speak about the impact of policies that deny insurance coverage for abortion, including and especially the Hyde Amendment. My name is Amanda Beatriz Williams, and I am a queer, Tejana, and daughter of an immigrant with a decade of experience in the reproductive health, rights, and justice movement in Texas. I serve as the executive director of the Lilith Fund for Reproductive Equity, the oldest abortion fund in Texas. Abortion funds exist to help people navigate the intricate web of anti-abortion restrictions, including abortion coverage bans like the Hyde Amendment that prevent people from obtaining safe abortion care. Lilith Fund provides direct financial assistance and emotional support to those in the central and southern regions of Texas and is one of 10 abortion funds serving our state. I'm also a proud storyteller with We Testify, an organization dedicated to the leadership and representation of people who have abortions to change the conversation to one of compassion and remind us that everyone loves someone who had an abortion. However any of us feel about abortion, politicians should not be allowed to deny someone's health coverage for it just because they're struggling to get by. Unfortunately, that's exactly what Congress has done for the last 44 years through the Hyde Amendment. Across the country, the Hyde Amendment has had devastating impacts for people unable to make ends meet, who are more likely to be women of color, LGBTQ people, immigrants, and young people. And for too many, coverage bans like the Hyde Amendment can act as de facto bans on abortion altogether. At Lilith Fund, we know firsthand the impact that coverage bans have on the Texans we serve. During the year 2019, 68% of Lilith Fund clients were people of color, 45% uninsured, 42% did not have paid employment, and they traveled an average of 158 miles to reach the abortion care they needed. The harms of the Hyde Amendment are further compounded by additional state restrictions, including state-mandated ultrasounds, medically inaccurate and biased counseling, and a mandatory 24-hour waiting period that forces Texans to needlessly delay their care. Since 2013, my state has also shuttered nearly half of its abortion clinics, forcing people to travel far distance and shoulder additional expenses. In addition to affording the abortion care, there are costs for travel to one's nearest clinic, lodging for overnight stays, lost wages from missed work, and childcare for the nearly 60% of our clients who already have children. On top of all of this, Texas restricts private insurance coverage of abortion, forcing people to pay completely out of pocket. These unnecessary delays can take weeks, forcing people to delay accessing care until later in their pregnancy. As the COVID-19 pandemic and economic fallout ravages Black, Brown, and Indigenous communities, the same people impacted by the Hyde Amendment are already marginalized by inequities in our healthcare system and systemic racism. Anti-abortion Texas officials also exploited the pandemic by banning abortion care in our state for nearly a month. During the first week of April, when the ban was in effect, half of our callers were forced to travel out of state to receive their abortion care. The average distance traveled by our clients in 2019, before the pandemic, was 158 miles, about the distance from DC to Philadelphia. But during the pandemic, when our callers were forced to travel out of state for their care, it increased to 635 miles, which is more than the distance from DC to Louisville, Kentucky. Even before the COVID-19 pandemic, almost 40% of Americans did not have roughly $400 saved to cover an unanticipated expense. For many of our hotline callers, expenses like groceries, rent, and childcare were already difficult to afford, but with so many losing their jobs this year, paying out of pocket for an abortion can be next to impossible. And I know this personally because the stress was all too real for me. When I was 19 years old and a freshman at the University of Houston, I had an abortion. While my decision was clear, the path to coming up for the money to pay for my care was difficult and nerve-wracking. I was privileged enough to borrow money and make an appointment. When I arrived for my procedure, I was overwhelmed by the kind support I received from clinic escorts, clinic staff, and my provider, who all made me feel comfortable and safe. And I keep them in mind every time that we're able to help someone get the care that they need. Everyone having an abortion deserves to be met by people who support them and care for them in loving and respectful ways every step of the way. And we deserve to be trusted. I also want to leave you with the story of another Texan, Rosie Jimenez, whose legacy we continue to honor in our work every single day. Rosie was a beloved mother and young child. Rosie was a beloved mother of a young child, a student, and a young Chicana living in McAllen, Texas in the late 1970s. Rosie was enrolled in Medicaid, but Medicaid did not cover an abortion at a clinic in her hometown due to the recently passed Hyde Amendment. Instead, she sought a cheaper, unsafe procedure and ultimately died due to complications. Rosie became the first known person to die as a result of the Hyde Amendment. And to be clear, Rosie died because of Hyde. When each of us can make our own decisions about our reproductive health care, when we can forge families we love on our own terms, we have more control over our lives and our economic security. It's long past time to strip the Hyde Amendment from federal appropriations legislation and help ensure that everyone, whoever they are, wherever they live, and however they get their insurance, can get the abortion care they need safely and without political interference. Thank you so much.
Thank you. Ms. Bennett.
Thank you. Greetings, Chairwoman DeLauro, and congratulations, Ranking Member Cole and members of the subcommittee. My name is Christina Bennett. I'm the Communications Director for the Family Institute of Connecticut, a wife, mother, and a pro-life advocate for the past 15 years. I was born in 1981, a year after the Supreme Court reaffirmed the Hyde Amendment. My mother faced intense pressure to abort, leading her to schedule an abortion at Mount Sinai Hospital in Hartford, Connecticut. The kind words of an elderly Black janitor who asked, "Do you want to have your baby?" gave her the strength to keep me. Before she left, the doctor pressured her to go through with the abortion, reminding her that she'd already paid for it. When she insisted on keeping me, he yelled, "Don't leave this room." My mother wanted me, even though she paid for an abortion. My mother represents women who've been coerced into abortion and receive substandard care from medical professionals. While working 4 years at a Connecticut pregnancy center, I served hundreds of women, some who were coerced by partners, kicked out of their homes, and left to continue with their pregnancies alone. For 44 years, the Hyde Amendment has protected vulnerable women like the ones I've known. Since 1976, the Charlotte Lozer Institute estimates the Hyde Amendment has led over 2.4 million mothers to carry their pregnancies to term. An estimated 60,000 lives are here because of the protection of Hyde. 1 in every 9 people born to a mother on Medicaid is here today because of the Hyde Amendment. And the Hyde Amendment has had 44 years of bipartisan support from Democrat and Republican legislators and voters. A mayor's poll released in January of 2020 found that 60%, or 6 in 10, American voters oppose taxpayer funding of abortion. The Hyde Amendment aids communities disproportionately impacted by abortion. Though Black women are just 14% of the childbearing population, we are 3 times more likely to abort, and we make up over 36% of the abortions. Repealing Hyde would lead to an increase in abortion in our community that already has high rates. Prior to Hyde, the federal government paid for an estimated 300,000 abortions yearly, accounting for roughly 1/3 of all abortions and forcing the cost of $45 to $55 million a year on taxpayers. Forcing taxpayers to fund elective abortions means low-income women of color will be prey for an industry that has been found guilty of overbilling Medicaid, accepting racially motivated abortion donations, selling fetal remains, manipulating medical claims to increase financial gain, as well as aiding sexual abusers. It is irresponsible and unjust for a federal government charged with providing aid to those dependent upon them to encourage the termination of their offspring. What message does it send to a woman who lives in a state where Medicaid won't cover her yearly dental exam, but she can get a free abortion? A recent poll found that 55% of low-income respondents said they specifically supported the Hyde Amendment. Although the Turnaway study is used to claim abortion as a benefit to women, Dr. Michael New exposes the study relies on poorly done surveys of a non-random sample in which nearly 70% of women refused to participate and half dropped out. its findings are not statistically valid for a general population of U.S. women. The Hyde Amendment is accused of being racist, but it's not racist to preserve Black lives. Hyde protects women from an industry that is actually rooted in racism, with a documented history of eugenics philosophy, population control, and the unlawful targeting of the Black community. This is why Planned Parenthood of Greater New York recently removed Margaret Sanger's name from their Manhattan building, looking to separate themselves from a leader who targeted the Black community through her Negro Project, thus leading to 79% of abortion facilities being located in lower-income minority neighborhoods. And former abortion workers have come forward to share stories of coercing women and being encouraged to reach abortion quotas. If unacceptable practices are taking place, then why should this organization or those like it be trusted with additional taxpayer dollars? Black women such as Cree Irwin, Lakeisha Wilson, Tanya Reeves have died at the hands of the abortion industry, while others have been wounded, like my dear friend Destiny, who spent 3 days in the ER after a Medicaid-funded abortion in Hartford, Connecticut, left fetal remains inside of her, almost killing her. Although abortion-related complications and deaths are underreported, I have heard stories of women who have suffered botched abortions and even those who are left infertile. Free abortions is not in the best interest of our community. We need healthcare, better housing, paid leave, affordable daycare. A study of over 7 million Medicaid-eligible women shows that having one abortion put them at risk to have another abortion, leading to hemorrhage and infection, 2 causes of maternal mortality. Abortion on demand is a band-aid to the wound of economic and health disparities that cause women to seek abortion. Please focus your efforts on better funding Medicaid across the country to improve the quality of lives instead of unjustly ending them. Thank you.
Once again, let me just say a very, sincere thank you to all of our witnesses for their testimony, and we're delighted that you're here today. What I'd like to do, we're going to start our questioning, and with that, if I can start here, we're engaged in a pandemic, and we have seen, in my view, the lack of leadership from the current administration, which has had devastating effects on the health and the financial well-being of all Americans. Now, clearly, these harms exacerbate what are existing inequities and fall hardest on the same communities that are adversely impacted by the Hyde Amendment. To all of you, and this is a question that comes from myself as well as our colleague, Congresswoman Jan Schakowsky, is how has the increased reliance on Medicaid and the need for reproductive and abortion care been affected during the pandemic? How have restrictions like the Hyde Amendment made it harder to access abortion services during the pandemic? Again, a question for all of you, and please jump in and start. There's no, Dr. Palacios, do you want to kick it off here?
Yes, thank you very much, Chairwoman, for that important question. As somebody who's had both the responsibility and honestly the privilege of working in many disaster situations, you are exactly right. Disasters exacerbate pre-existing inequities. This is true whether it's infections such as we're seeing now. It's true whether it's hurricanes such as Hurricane Katrina. In this current environment where we have an unprecedented confluence of a global pandemic, massive economic crisis, and a racial reckoning, it is critically important to understand how all of these things, 3 things, interface, especially how they interface in people who have been historically marginalized, either because of their race, their ethnicity, or their lack of wealth. At Guttmacher, my colleagues conducted a survey in April and May, just months after COVID began shaping the American landscape. We discovered that Black and Latina women were more likely than white women to want to delay pregnancy or to have fewer children because of the pandemic. Simultaneously, they were also more likely to experience delays in sexual and reproductive care or have trouble getting birth control. So at the same time that they were trying to make important decisions for themselves and their families because of the situation around them, they were having trouble accessing the very services that they needed to get to be able to make those decisions. This is a matter of dignity. It is a matter of people being able to get the affordable care when they need it. They're needing to make decisions about when to have children and how many children to have doesn't suddenly stop being important because there's a global pandemic. In fact, it may be more important than ever as people are trying to protect their own safety and their economic well-being.
And
Dr. Parrott?
absolutely. I'll just add to that to say that the same inequities in healthcare delivery that we're seeing in communities in accessing care more broadly, including access to care to alleviate the impacts of this global pandemic, are the same ones that are playing out when we're thinking about restricted access to abortion care. The reality is that access to healthcare, including abortion, shouldn't depend on where you live or how much money you make. Healthcare is a human right, and insurance programs should cover the full range of reproductive healthcare services, including abortion. We saw, as a result of the global pandemic, attempts to eliminate access to abortion care. We heard what Amanda talk about what's happening and what happened in Texas as a clear example of that. So understanding that people have the right, patients who rely on Medicaid and other federal programs for health insurance should have the same access to healthcare services as those who have private insurance, and understanding that as justice is really important.
I've got about 38 seconds left to go. Ms. Williams, Ms. Bennett, and I can come back afterward because I'd like to get your views. Ms. Williams?
Yeah, thank you, Chairwoman. I'll just add that, even before the pandemic, these communities that are disproportionately affected by COVID-19 are struggling to put food on the table. They're worried about making rent on time. They're worried about paying for diapers. Their mothers caring for their families. And so I think especially now, because of this pandemic, we should be coming together to be thinking of solutions for expanding healthcare and not withholding coverage for it.
Okay. My time has expired, but Ms. Bennett, I'll catch you and, so that you can have an opportunity to speak as well. With that, let me yield to Congressman Cole.
Thank you very much, Madam Chair. If you want to take a minute and finish out, go right ahead.
Any comments, Ms. Bennett?
Sure. We are in a pandemic, and it's obvious that there are millions of Americans who are suffering, even in my own community of Middletown. I'm making sure to give to St. Vincent de Paul's and different charities because people are in need, and food lines and food banks you're reaching capacity. But this puts women who are pregnant, who are already vulnerable, in an even more difficult situation. And it's important to make sure that they aren't going to be coerced to have an abortion because of the fact that they are in a difficult situation. Because most women who have an abortion already are doing it because of financial lack. And what they need is resources. They need support. They need aid, not the termination of their children, which is a decision that they can never come back from. And so I would say that in this time when women are increasingly vulnerable because of what's happening with the pandemic, we have to give them support, not take something away from them that is so precious.
Congressman Cole.
Thank you very much, Madam Chair. I'll follow your lead and actually ask one question to all the panelists, and the yes or no question, but you're certainly free to elaborate if you have something you want to add. Do you believe that federal taxpayer dollars should be used to pay for abortion on demand at any stage of pregnancy for anyone who seeks an abortion but says they cannot afford one? So let me start, as you did, Madam Chair, with Dr. Palacio, and then sort of work across the panel, if I may.
Thank you, Chair. Thank you, Representative Cole. We're here to really think about what's important is about covering insurance for medical care. Abortion is a healthcare procedure. What we're talking about is the discrimination against people who are low income or people who are typically Black and brown, who aren't able to access affordable timely services in the same way that you or I are. It is an important issue of equity to be able to have Medicaid pay for a robust comprehensive services, and robust comprehensive services includes the full spectrum of reproductive services, including abortion.
Thank you very much. Dr. Parrott, same question.
Sure. Thank you for that. Not surprisingly, I agree. I believe that healthcare is, as I stated, a human right, and that every person has the right, whether they're getting their health insurance through the federal government or through private insurers, to have access to the same services. The community that I take care of, the patients that I see, should not have to make decisions based on their economics and incomes. And it's not either or. They also need support. They also need childcare. They also need prenatal care, right? It's a both and, not an either or.
Okay, and Ms. Williams?
Yes, thank you, Representative Cole. The reality is wealthy people will always be able to access abortion care because they have the means to do so. What's really at stake here is the discriminatory policy that is jeopardizing low-income people's lives and futures. When we withhold coverage from someone who's enrolled in Medicaid coverage, we're telling them a message, a stigmatizing message that they are not worthy of safe, affordable healthcare, and that we do not care about their rights and we will not uphold their rights, their constitutionally protected right to an abortion. So this has been on the books for far too long. We need to start telling them a different message, one of compassion, one of support, and we can show them that by covering all forms of healthcare, including abortion.
Thank you. And Ms. Bennett?
Saying that abortion is just healthcare or that abortion is merely a woman's right denies the reality that abortion is a destructive act through violent means that ends the life of a human person. If I was aborted in Hartford, I would have been dismembered. My body would have been thrown into a trash can. And that would have been the reality of what happened. And we can use all sorts of words to describe abortion, but we can never deny the fact that abortion is the intentional taking of a human life. And taxpayers who are morally opposed to this, whether it's for religious reasons or secular reasons, should not be forced to have to fund this, especially for those of us in the Black community who view abortion and what has happened to our community as an act of genocide. We should not have to work hard to give our money to institutions that take innocent lives.
Thank you. Ms. Bennett, let me follow up with a question on that as well. You mentioned in your testimony, we can both love women and children and strive for a society that treats us all with dignity, the dignity that we deserve. What are the best ways to provide, honestly, for this empowerment, for care for women in financial need, for facing unwanted or unexpected pregnancies? What are the services, what are the things we should make available to folks in that circumstance?
Thank you for that question. There's so many ways that we can provide. I worked at a pregnancy resource center for 4 years, and we were offering free at no cost to women, parenting resources, parenting classes, emotional support. We were throwing baby showers for them. We were helping them to find jobs and helping them with doing resumes. We were really getting involved in their lives in a personal way because many women are abandoned. My own mother, even unfortunately, I didn't mention this in my testimony, but when she went to church when she got pregnant, and her mentor at church told her, don't come back here because you're pregnant out of wedlock. And so she was rejected by people that she loved. But we have the opportunity to serve pregnant women and to love them, providing these resources and support that they need. In addition to that, we have to change laws, and we have to make sure that the government is taking care of them through programs that we already have, like WIC, like SNAP, that provide for mothers and provide for their children, but as well as providing for housing, because so many pregnant women are at a lack for housing. So many pregnant women are struggling with transportation. They need paid parental leave. They need affordable daycare. They need better health care. So we all have a part, whether you're in a religious institution, whether you're in the government, we can all pitch in and we can all help because the need is so great.
Thank you very much. Thank you, Mr. Chair. Yield back.
Yes. Congresswoman Lowey.
Thank you very, very much. This question is for Dr. Palacio of the Guttmacher Institute. My staff recently reminded me of a floor speech I gave in 1993 before the House voted to reimpose the Hyde Amendment on the labor HHS bill. In it, I spoke of the human face of Hyde, of Rosie Jimenez, as Miss Beatrice Williams mentioned, a 27-year-old college student too poor to pay for an abortion and unable to access coverage for a safe and affordable procedure due to the Hyde Amendment, who died in agony after a botched back alley procedure. We have failed Rosie and countless women like her. Dr. Palacio, your testimony referenced the Hyde Amendment's disproportionate impact on women of color. Can you provide more detail about the compounding effects of racism on your patients, and in particular, how Hyde disproportionately harms women of color?
Thank you very much, Chairwoman, for that question. Such an important issue. And I want to begin just by reflecting a little bit on the last answer. And I'm very grateful that Ms. Bennett's mother was able to choose to carry a pregnancy to term when she wanted. I'm equally grateful that Ms. Williams was able to terminate a pregnancy when she wanted. This is reflective of what reproductive autonomy really is. It's about assuming that women have the agency to make decisions for themselves. It is about assuming that women have the full capacity to make dignified, human, and humane decisions for themselves and their families. The Hyde Amendment builds on the legacy of racism. There is a direct line from the reprehensible policies of our past, such as forced sterilization of Black women, to policies like the Hyde Amendment today. There is a direct line from the fact that enslaved people even when they had their children, were told they couldn't parent those children, and those children were placed elsewhere. There is a direct line from the way that Black bodies have been experimented on, and forced sterilization was the rule of the day. You cannot remedy a racist history by continuing racist policies in the current and into the future. So these are both true. Yes, we have a racist history, and yes, Hyde is a racist policy. These are not incompatible truths, and it's time to remedy the past by taking this bold step for the future, and I thank you for your leadership on this issue.
Dr. Parrott, as a physician, in your experience, how has the Hyde Amendment impacted the patients you treat? Specifically, have you had a patient unable to pay for an abortion because her insurance restricted coverage? And what are the health impacts and risk of delaying an abortion to later in pregnancy?
Thank you for that question. Yes, unfortunately, it's all too common that we see individuals, especially here in the District of Columbia, who don't have insurance coverage for abortion services. As I mentioned, there's a large community of folks here in DC who work for the federal government who are excluded from coverage for abortion care. We also we're voted to be unable to use our own tax dollars to pay for abortion coverage, despite the fact that DC voters wanted to do so because we lack home rule here in the district. And the reality is that it creates a situation where folks are really making very difficult decisions. Often people who are having abortions also already have children, and so they know what it means to parent. This is not a theoretical concern or a theoretical risk. I trust the people that I take care of to know what is best for them. They need access to the care that they decide when they need it. Delaying care does not eliminate access to care. It just pushes it further away and out of reach for more people. We have robust data from the Turnaway study that tells us this. And beyond the study data, I talk to patients every day that I'm providing care. who are clear about their decision, who articulate the risk to them and the children that they're already parenting. And so the risk is not in theory, it is real, and it is real people that we're talking about.
Well, I see my time
Time
has
is right.
expired, so I yield back, and I thank you very much, Madam Chair, and it's wonderful seeing you sitting there as our Madam Chair.
Thank you.
Thank you.
Thank you. Thank you. Congressman Harris.
Thank you very much, and thank you everyone for appearing today. First of all, there's been a claim that Hyde is somehow to blame for delays in medical care, but the state of Illinois did a study from 2013 to 2016 that actually 752 Illinois enrollees, Medicaid enrollees, died while waiting for care. So this is a problem with Medicaid in general, not necessarily with the Hyde Amendment. Dr. Parrott. Well, with regards to home rule, you have to take that up with the U.S. Constitution. But I would, and Madam Chair, I asked to offer into the record a article from the National Review entitled "A Flawed Study Claims That Few Women Regret Abortion," that discusses the problems with the Turnaway study.
Sword.
Okay, so Dr. Parrott, I think it said somewhere in your history that in your bio that you're licensed in Maryland. So I'm sure you're aware that in Maryland, there really is no functional barrier for Medicaid women to have abortions. Is that right? Dr. Parrott?
That question is misleading. There are a number of barriers to accessing abortion care in the state of Maryland.
Okay, well let's go through the figures, because in 2017, only 18% of Marylanders were covered by Medicaid. But 27% of the abortions performed in Maryland were funded by Medicaid. So actually a disproportionately higher number, and you and I both know it's through the mental health loophole, because in the last year the data is available of the over almost 8,000 Medicaid funded abortions, and it was funded through state funds. I agree, Maryland agreed to do it, but in Maryland there actually is no functional barrier to that. Is that right, based on the statistics?
No, that's incorrect. The patients that I talk to every day can identify any number of barriers to accessing care. You mentioned barriers to accessing care through Medicaid more broadly. The same is absolutely true for accessing care to abortion.
Okay, but the figures will show that in fact a higher number of Medicaid patients actually have their abortion paid for with public money, albeit state money, but public money nonetheless. The risk to health, I assume, and I think the chairwoman mentioned the risk to health, but in fact, in Maryland, the data is that it's all mental health. Now, Dr. Parrott, I don't know if you've ever done an abortion in Maryland or done it on a Medicaid patient with a mental health referral, but are you aware that an abortionist who claims that there is a mental health issue does not have to refer for mental health care? You're aware that that requirement does not exist, is that right?
Well, I'm aware that patients are in the best position to decide whether or not continuing the pregnancy would pose long-term mental health impacts to their life. And the patients that I take care of, I talk to them about that, and I believe them when they say that this is something that will be harmful to them. I trust their response and their view of their health.
So, Dr. Parrott, globally, is that the way you feel about mental health care? That basically we don't really need it because people can kind of decide what is in their best interest or not? That's a rhetorical question. You don't have to answer it.
I'd be happy to answer it.
No, but that's okay. It's you don't need to. Christina, could you go over, because you mentioned the problems with Planned Parenthood, and obviously, I wish Planned Parenthood, which is a C3, the money they got from selling baby body parts, I wish they had actually funded abortions free for some of their clients. But you mentioned the sexual abuse issue, and we know that there are numerous reports of Planned Parenthoods providing abortions when the client has said they're underage, and for instance, the father is an adult. Is this what you're referring to, Christina?
Yes, that is actually what I'm referring to. Specifically, I'm referring to a study by Live Action, which is an organization that I work with. who has talked to different women who've been abused, and unfortunately that's been covered up by Planned Parenthood, and they have a report that you can find online called Aiding Abusers, where it goes into that information. I personally, as I mentioned before, I live in Connecticut, which is a state that does not have parental notification laws. So that means that minors are allowed to access abortion without even notifying their parents. And at the same time, we are in a state, like many states across the country, where we have horrible reality of sex trafficking, where women are being taken advantage of. And it's not hard to understand that for women who are taken advantage of through sex trafficking, for them to be able to keep those girls and those women in business, they have to make sure that they do not keep their pregnancies. Obviously, they become pregnant because they are being raped brutally over and over again. But one of the ways in which they make sure that they can go back to business is by taking them to abortion providers. And it's easier in states like Connecticut, where there's no parental notification laws, because then traffickers and pimps and abusers can take underage girls to get abortions, and there's no questions asked. And so this is a reality that we don't often like to talk about, but it's horrible.
Thank you. I yield back.
Congresswoman Lee.
Thank you very much. Let me thank you and congratulate you, Congresswoman Chairwoman DeLauro, for your commitment, and your passion and your clarity of the purpose of the Hyde Amendment being not included in the next appropriations bill. And I want to thank you so much, along with our committee members, for this hearing today. It truly is really a historic hearing. It's a long time coming, but it's important that we discuss these issues within the context of what we know, and that is the context of racial justice. With the COVID-19 pandemic, we see just how inaccessible healthcare, especially reproductive health care and access to abortion for women of color and low-income individuals is. I want to just thank our witnesses today for being here and for sharing your experiences with the subcommittee. And let me take a moment to thank the All Above All Coalition, who have worked so hard to ensure that we finally begin to end this discriminatory policy, such as the Hyde Amendment. I do co-chair the Pro-Choice Caucus and the lead sponsor of HR 1692, which is the Each Woman Act. And so this hearing is especially important to me. Also personally, I just have to say once again, I remember the days of back alley abortions. I remember the days before Roe versus Wade. I know exactly the decisions, the crucial decisions, the heart-wrenching decisions that go into especially young girls having to make decisions, and women having to make personal decisions with whomever they decide as to whether or not they choose to have an abortion for whatever reason. And so this is extremely important that we recognize that the policy of the Hyde Amendment has been discriminatory against women of color and low-income women, and that that the history of this also be remembered, because I want to remind you, and I just want to say, first of all, I was a staffer when the Hyde Amendment passed, and Henry Hyde said that those that would be impacted would be little ghetto kids. So, Dr. Palacio, let me just ask you, because we started talking about systemic racism in the moment that this day is in terms of the racial reckoning. But the history of how we got to this point is so important, because sometimes systemic racism is overt, sometimes it's subtle and covert. But the facts speak for themselves. So can you just once again continue along your line of testimony as it relates to the history and why people need to understand how structural racism works within the context of the Hyde Amendment?
Thank you very much, Congresswoman Lee, and thank you for your leadership on the Each Woman Act. It is critically important to contextualize the moment that we're in and the Hyde Amendment and understand the arc of history rather than view it as an isolated thing. As I said, the history of Black and brown people not having autonomy over their own bodies is long and steeped in our society. And these are not accidental occurrences. These are occurrences that are the result of law, regulation, and policy on the governmental level, and sometimes a result of institutional policy at the organizational level. The very fact that Black and brown people are disproportionately represented among Medicare is not an accident. That is a result of the long history of economic policy, of housing policy, of educational policy that has made it very difficult for Black and brown people to enjoy the same accumulation of wealth over time. These things are related. We need to understand that where we are now is a direct line from where we've been, and that the only way to change that is to take a different action. And the action that this committee is considering today to pass a clean appropriations bill without the Hyde Amendment is one, but only one of the critical steps needed to change the trajectory of history to the future so that we don't continue down the same path, overlaying racist policy on top of racist policy.
Thank you very much. Thank you very much, Madam Chair.
Thank you. Thank you. Congresswoman Herrera Butler.
Thank you, Madam Chair. You know, I have some questions, but can you hear me? Can you hear me okay? Okay.
Yes.
You know, I need to start by saying, as a woman of Hispanic descent, a woman of color who came from, you know, I think about my dad growing up as one of 10 Mexican Americans, at times in a one-room house where they didn't even always have running water. I just have to say I completely fundamentally reject the notion that getting rid of one of those 10 or more of those 10 would make life better for the rest of them. It just doesn't work that way. I mean, we're talking about a human life. And to me, you know, the Hyde Amendment strikes a really important balance. We're not talking about where the life of the mother is in danger. We're not talking about life for life. We're talking about someone who is, you know, it should be protected under the Constitution as having that life. We know, the doctors on this call can tell you, that a baby in utero can have a completely different blood type than its mother. It's not an extension of the mother's body. It's its own life with its own DNA that is separate from the mother's. So we keep taking this back up to just talking about one person in the equation, and that's the mother, but you have to acknowledge the personhood of the other person in this equation who pays the ultimate price. And I reject the solution that Dr. Palacio proposed to maternal mortality rates to decrease them, is to just get rid of pregnancy. We know that 70% of women who experience maternal mortality or those complications, it happens actually during that first year after the baby's born, which is why I proudly supported extending Medicaid coverage to the mother to cover the mother and the baby during that year when we know most of those things occur. I proudly supported. It was one of the reasons I voted against our party's Obamacare repeal. And I told Vice President Pence, look, if we're going to tell young women who are poor or who are from minority neighborhoods, have your baby, then we need to step up and make sure that they have the coverage they need. And the wraparound services is why I support family medical leave. It's why I support these services, because I'm putting my money where my mouth is. I think one of the things that keeps getting lost here is we're talking about the Hyde Amendment as in some way it's racist. The reality is, the Hyde Amendment is one of the things that helps us root out systemic racism in this area. Women, 33% more women of color have abortions, and it's no secret that Planned Parenthood's founder had built this whole methodology into place to go into these areas with a eugenics mindset to get rid of poor Black women. Oh my goodness, that's so outrageous to say that because you're poor or because you're Black, you use the solution for your life and your success is to take away your pregnancies. I mean, I just, it's hard for me to understand that this is how we're talking about this. And I wanted to make the point, there's a couple points. 70% of Americans, this is from June of 2020, Gallup, want abortion to be illegal in all circumstances or legal only a certain narrow subset of circumstances compared to 29% who say abortion should be legal at any point during pregnancy. We're not talking about private funds, we're talking about taxpayer funds. The Hyde Amendment has 40-year legacy of being bipartisan. It has a 40-year legacy of enjoying the support of the American people. Some of the arguments I keep hearing are, women need to be able to make this decision on their own terms, with their own bodies, reproductive autonomy, but they're not using private dollars. We're not talking about them using their own dollars, right? You're asking for taxpayers, 70% of whom do not wish to have their money sent here. That's what we're talking about. We're not talking about overturning Roe v. Wade. We're talking about protecting this taxpayer funding and people's conscience here. And one thing I wanted to hear Christina Bennett expand upon this with regard to the allegations that somehow the Hyde Amendment is racist. I view it quite opposite.
Well, I view it the same way that you do. I share your thoughts. I think it's absolutely ridiculous. I'm alive today because my mom walked outside of her abortion appointment. And so to think that encouraging abortion, and make no mistake, that's what this will do. It'll encourage abortion. When women are already vulnerable, they will think, all I have to do is just go over to the clinic and give them my Medicaid card and my life can change. They'll believe the lies that society tells them, that their problems will be erased. Their partners may be pressuring them. Their parents may be pressuring them. I have been outside of abortion clinics. I have seen mothers dragging their children, their teenagers into clinics. I have seen guys pressuring their girlfriends and even their wives. And this makes it easier for them if they know it's free.
Let me add in my last 17 seconds. Thank you for that. Studies, including a study specifically of poor women on Medicaid in California, show much higher death rate for women who have had abortions compared to women who have given birth, especially from suicide. This needs to be explored.
Congressman Pocan.
Thank you, Madam Chair. And if I can, since this is the first time I'm seeing you since you've been elected to be the Appropriations Chair, I just want to say congratulations. You have been a mentor to me since I came into Congress. Your passion, your energy is contagious. Your values are impeccable, and I'm really looking forward to the 117th Congress. So I just
thank you.
Thank you. Thank you to the witnesses, and I guess let me offer it from this perspective of being a white man who makes the salary of a member of Congress. I am unlikely to personally intersect with the Hyde Amendment in my life, although largely it is people like me who've made these decisions for everyone else in the country. I believe in healthcare. I think healthcare is healthcare, exactly that. And if you have to give it to people who need it, and discrimination based on someone's income, essentially, is what the Hyde Amendment is just that, discrimination. And hearing Ms. Williams, your story about, your very personal story, thank you for sharing that about having an abortion when you're 19, but having to talk about clinical escorts, I can't think of a cancer patient or an HIV patient or a heart disease patient like myself who's had to have clinical escorts in order to get health care. And just the idea that is a debate in 2020, although 2020 is quite a year, I will admit, but the fact that that's still a debate at this point, I find rather amazing. I guess I'd like to ask questions of our two doctors, Palacio and Parrott, since you are physicians and this is about healthcare, even though the Hyde Amendment necessarily isn't, but the idea of abortions is healthcare. Let me ask you the question, is there anything else that you know of that's explicitly banned by federal law, that's healthcare based on income, that people can't do other than the Hyde Amendment? Is there anything that stands out in your practice? Dr. Palacio first, and then maybe Dr. Parrott.
Well, thank you so much, Congressman, for that question, because I want to contextualize a little bit of what we're talking about here, which you elucidated so well, which is the stigmatization of individuals. And as somebody who really was working in the height of the epidemic in San Francisco with people who were infected with HIV and AIDS, predominantly men and women of color was my particular patient population. I can tell you that we have a history of stigmatizing people by their characteristics and not being willing to pay for their care, right? The Ryan White the Ryan White Care Act was because we didn't have sufficient public funding through Medicaid to take care of people who were living with HIV because they were perceived not to be worthy of that kind of care. We have a history of having mental health services not funded very well by public dollars because people who were mentally ill were perceived to be crazy and other stigmatizing ways and not seen worthy of taxpayer dollars being used to fund their care. We have a history of people with substance abuse disorders not being able to get comprehensive substance abuse treatment care because they were seen as other and not being worthy of getting care. So this is not isolated, and it's important that we recognize it for what it is. Women who seek an abortion are being systematically characterized as other and not being worthy of getting their care covered.
Thank you for that question. And I'll just join Dr. Palacio in talking about some of the other ways that reproductive health, particularly reproductive health care and decision-making for low-income women is also stigmatized. It shows up in how we decide who gets coverage for assisted reproductive technology, for example, and for different kinds of contraception. And so we decide that for poor people, we won't cover things like help getting pregnancy or fertility examinations or evaluations. So banning coverage for abortion is part of a larger schema in which we decide that for women who are disproportionately communities of color and rural people do not have the agency and autonomy to decide what is best for them, for their lives, and for their bodies.
And thank you for actually helping me define that question more, because I think we know there isn't more in this category where we ban someone from getting healthcare, but really raising the stigmatization that comes out of doing this by having something banned simply because of people's values rather than the science. And I thank you both for that. I yield back.
Congressman Molinar.
Thank you, Madam Chair. I was having a little trouble unmuting there.
I know the feeling.
I want to thank our witnesses also, and just to follow up on the previous discussion for a moment, you know, I feel like when we start talking about care or services related to abortion, we kind of forget that, you know, an innocent unborn child that is created in the image of God is not a disease, a cancer, an HIV/AIDS, a virus, or a substance that's being abused. It's a child. And I just want to put that on the record, because when we're talking about science, I think the science more and more is indicating the importance of recognizing the value of these innocent human lives. I want to begin by asking Ms. Bennett, you'd mentioned your mother, and thank you for sharing your story. And I also, you mentioned that women like your mother would need resources and support as they're going through a challenging time. And, you know, you mentioned in your written testimony in the state of Connecticut, housing for young mothers beyond homeless shelters is hard to come by, and lament that St. Agnes Home, a faith-based home for teenage mothers, closed in part because the state stopped referring clients and providing funding. And I can relate to that because in my home state of Michigan, we've recently seen a similar loss of support for women who have chosen to carry their baby to term. And in 2019, the Michigan Pregnancy and Parenting Support Services Program received $700,000 in the state budget. Funding is of the state's $58 billion budget. But the legislature and governor were unable to agree on funding, and it was unfortunately vetoed. And without this funding, many pregnancy centers throughout the state will either be forced to reduce their, shut down their. June of 2014, they've served 8,393 clients. 98% of the women were connected to a healthcare provider for prenatal care. 94% took their child to pediatric appointments. 93% kept their child's immunizations updated, and through 2 local providers alone, Pregnancy Aid and Catholic Charities of Southeast Michigan, over 2,600 women have received support services at no cost to the mothers or their families. And Ms. Bennett, I'm wondering, how do you think the loss of programs like the Michigan Pregnancy and Parenting Support Services Program, as well as St. Agnes Home, affects low-income women?
Well, I believe that it hurts them. And I have personally sat next to women who are in need of housing and called shelters just to hear that they were full, especially in the long winters that we have here in Connecticut. And thankfully, I have been able to turn to a few faith-based organizations like the Nehemiah House and the Malta House, but it's just not enough. And you mentioned the great work of pregnancy resource centers, and I want to let you know and to let everyone know that in Connecticut, they're under attack. The Democratic legislators are literally trying to shut them down by bringing forth false legislation, accusing them of manipulating women and having false advertising. So these pregnancy center leaders have to take time away from helping women to go to the LOB and to defend themselves year after year against these false allegations. So not only do we in our state not have enough support as we need for women that are in crisis and don't have housing, but at the same time, the very people who out of the goodness of their heart are freely offering services to women in need, they have to defend themselves. I've had to go multiple times and speak out and testify and defend pregnancy centers from these lies from pro-abortion radical groups. All the while we're funding abortions. The Catholic Conference says in Connecticut that 75% of the abortions here are funded by Medicaid. It's just wrong. We are punishing and hurting the women who are helping, and we are aiding those that aren't.
Well, and that's a point. I guess I'm wondering if your line of work, you've met women who have been harmed by abortion or regretted a previous abortion or have even been coerced.
Yes, absolutely. I've met women who had suicidal thoughts after an abortion. I met women who every year they'll think about how old their child would have been, and they'll see another child on the playground and think, my child would have been 5 years old, or my child would have been 6 years old. I've met women who had a previous abortion, and then when they got pregnant again and they saw their baby on the ultrasound screen, they felt guilt and remorse because they didn't realize their baby, the one that they aborted, looked like that in the womb, was that developed. So I have heard so many stories. I've met women who've had an abortion 30 years ago, and they still have tears in their eyes because they've never really been able to heal from the trauma. And I will say, that is not everyone's story. I will say that there are some women who told me, I've had an abortion, I was fine. I've had women say, I've had 6 abortions, I was fine. But every woman's story is different, and many of the ones that I have met have had pain and remorse and guilt. That's why there are post-abortion healing programs all throughout the country, like Support After Abortion or Rachel's Vineyard, because there is a need for them.
Thank you
very much. And I know over my time, and thank you. I yield back.
Representative Clark.
Oh, thank you, Chairwoman DeLauro. I just also want to add my congratulations and my deep gratitude for your leadership, your sisterhood, and as Ranking Member Cole noted, we know that this will still be your favorite subcommittee as we move into your chairmanship. So congratulations again, and really looking forward to the next Congress. And I think this hearing is an example of exactly the issues we need to be addressing as we sit at a nation in the middle of a pandemic, but also at a crossroads of how we are going to address racial and economic justice in this country. And there is no way to fully address either with the restrictions of the Hyde Amendment in place. And we see this play out for women, 40 million women who are enrolled in Medicaid across this country. And it does come down to not just a matter of reproductive freedom, but a matter of economic freedom. And so my question is for Ms. Williams. We know that women are the backbone of our economy. We know that this pandemic and the resulting economic fallout has disproportionately affected women, as we see 1 in 4 women leaving the workforce. But the reality is we still are interfering in these deeply personal decisions for women through the Hyde Amendment. So I'm hoping you can help us understand how access to reproductive choice affects economic outcomes for women. And is there evidence to suggest that being denied access to an abortion has persistent negative effects on a woman's financial well-being?
Yes, thank you, Representative, for this question. And thank you again for inviting me as someone who has had an abortion and can speak to my own experience. Studies show that when policymakers restrict Medicaid abortion, about 1 in 4 low-income people seeking abortion are unable to obtain one. I mean, the data is there. We have heard from our renowned physicians and doctors on the panel that there are a number of outcomes for people who are denied access to care. And today, this is not a question of whether or not we believe abortion is the right decision for anyone, because we don't know what everyone's circumstances are. But the solution is not to deny someone access to that care. That is their constitutional right. In my own experience, as I mentioned before, I have had an abortion. I was working 2 jobs. I was in classes full-time as a young person in a new environment at the University of Houston. And I was focusing on pursuing my own education and building the future that was best for me. And having a child at that time wasn't what I was ready for. It's not what I was, not what I wanted. And economic security was a big factor in my decision, but like all decisions, there are complexities and nuances, and economic security wasn't the only factor. I needed an abortion because I needed to be in control of my own body and my own wellness. And being able to access my care was about affirming the fact that I am the expert in my own life. And we give everyone that we help on our hotlines that same dignity, without shame, without stigma, and without judgment. And we should be able to make these kinds of healthcare decisions with trust and dignity and respect. And it should be covered like any other form of healthcare, because it does have such long-term effects on the trajectory of our entire lives. We do not make these decisions without, we don't make any vital decisions about the future of ourselves, our families, and our communities with, we do give it the kind of thought that it deserves, and to assume that we don't make the best decisions for ourselves is insulting.
Thank you. With 30 seconds remaining, Dr. Palacio, do you see a tie to the Hyde Amendment and maternal mortality outcomes for women of color?
I think they're part and parcel of the same underlying problem, which is that Black and brown women can't access the care when they need it, the right care, the right time, in an affordable way, in ways that are not the same as a way that, frankly, majority white populations or wealthier populations have access to that care. So they are clearly manifestations of the same type of, frankly, wrong-headed approach that we have to allowing Black and brown and low-income communities to access the quality care, affordable care in a timely manner.
Thank you. Thank you, Madam Chair.
Thank you. Congresswoman Frankel. Unmute. Lois, unmute.
Okay, I got it.
Okay.
Hi, everybody. Hello. Thank you, Madam Chair. Congratulations on your new role. Nita Lowey, I'm going to miss you. Love you. Thank you for all you've done for us. And thank you, everybody on the panel today. So I wanted to start off by saying that, my proudest achievement is my son, Ben, and my greatest joy is my grandson. And with that said, I want to just say that you could put me firmly in the pro-choice category. I believe that access to full reproductive care by women is a necessity for them to have full productive lives and to take care of their families. And thank you, Barbara Lee, for your leadership on this issue to get rid of the Hyde Amendment. You know, I just doing a little bit of research. In 1965, and this is before Roe v. Wade was instituted, illegal abortions made up about 1/6 of all pregnancy-related deaths. Today, abortion has a safety record of over 99%. So if your concern is about life, you do want women to have full access to safe legal abortion. You know, we were all pretty horrified when we saw the brutal murder of George Floyd. And there was a real awakening, or I should say a reawakening for many in this country about systemic racism and injustice. And to me, the Hyde Amendment is one of the best examples of this systemic racism. You know, you think about it, the Supreme Court gave us, in Roe v. Wade, gave women the right to access to safe legal abortion, a constitutional right to safe legal abortion. There are certain limitations. With that said, with the Hyde Amendment, that right is really for people who can afford it, people who can afford access. And I asked my friends who support this Hyde Amendment, would you deny a poor woman to go into a church, or freedom of speech, or freedom to be free from search and seizure, unreasonable search and seizure because of their color of their skin, because of how much money they have in their pocket? And I'm sure that answer would be no. So with that said, I do have a question. Ms. Williams, you testified about the harms of the Hyde Amendment being compounded by additional state restrictions. I would like you, if you could, give some more examples, and I would ask Doctors Palacio and Dr. Perrott to also comment on that.
Yes, thank you, Representative. As I've mentioned in my testimony, you know, Texas is one of the most restrictive states on abortion access, and there are a number of state level restrictions that make it very difficult to access abortion care. And on top of that, we do have restrictions on private health insurance, as well as, of course, Hyde. And in Texas, the majority of our counties are without a local clinic. And so this means that a lot of people in my communities are traveling potentially hundreds of miles to get to the nearest clinic to them, which can be very expensive. So we're talking about childcare. Again, the majority of our clients are parenting, caring for their families. So that also means, you know, childcare expenses, or potentially taking their child out of school, bringing them with them on what could be a multiple day trip because of a mandatory 24-hour waiting period. It could be a minimum of 2 separate appointments. And this also means that, you know, without paid sick leave, people may have to, you know, forego wages, take time off from work if they're even able to, if that's an option for them. And this is also a matter of overnight stays. This is an entire ordeal. It's a logistical roller coaster for people in my state to access an abortion care in a safe way, and it is a time-sensitive procedure. And I also just want to add that because of the COVID-19 pandemic, we're, you know, we should not be forcing people to travel any more than they have to, or bringing themselves or their child outside of the home to potentially expose themselves to the risk of COVID-19. So all of these factors really compound and can make it extremely difficult for people to access the care they need, on top of being able to pay out of pocket potentially hundreds of dollars and dig into their savings.
Congresswoman Watson Coleman. 。 Bonnie? Can you unmute? No. We need some technical assistance.
Oh,
for
I
Congress-
do.
Got
Thank
it.
you very much,
Okay.
Rosa. First of all, I don't know if Nita is still there, but I just wanted to say to her that last night's hanging of her portrait was so touching, and the wonderful things that they said about her and her leadership are the things that I experienced in my few 2 years on this committee. And I'm so glad that, Rosa, you will be taking up the mantle here. What you've done today is an illustration of kind of proactive, very progressive policies that you are committed to, and your leadership is authentic, and your concern is indeed authentic. So I look forward to working under your leadership. So I'm like really a bit concerned here because I have heard from a number of organizations, faith-based organizations, organizations that are women of color, organizations that are Latina organizations and affiliations, as well as Asian and Black. And all of them have solidly come out in support of the elimination of the Hyde Amendment in our appropriations language, and ultimately the repeal of the Hyde Amendment. I think a lot of this discussion has revealed that, can you hear me? Okay, I'm sorry. A lot of this discussion has revealed that there are lots of restrictions in access to healthcare that negatively impact poor women and Black women. And the Hyde Amendment is most definitely one of them. I was going to ask about the impact of COVID-19 on it, but I think I want to shift now to a discussion about these restrictions on abortion and how they negatively impact long and short-term healthcare outcomes for both maternal and infant mortality and morbidity. And I wanted to ask both of the doctors, Dr. Parrott and Dr. Palacio, to respond to that specifically. What is the outcome, the negative outcome for women who are, first of all, we don't take the need or desire to have an abortion lightly. It is a decision that comes out of our personal experience and need. And so to suggest that this is an issue of coercion and other things just really kind of throws me off and makes me very concerned that we're not really expressing what's actually happening here. But Drs. Palacio and Parrott, could you please talk to me about the impact of the Hyde Amendment, as well as in general, the kind of unequal access that Black women in particular and poor women have had to healthcare and to the right to have a safe abortion based upon their needs?
Yes, thank you for that question. You know, I've been practicing obstetrics and gynecology for more than 15 years, and I'm honored to have had the opportunity to provide the full range of reproductive health care to thousands of patients over this time. And whether it's delivering babies or providing compassionate abortion care, I'm really moved by the trust that my patients extend to me to listen to their needs, to discuss their unique circumstances, to provide them with the safest care possible. I too am troubled by the description of coercion by some of the testimony, because what it tells me is that those folks who believe that are happening really don't trust any women, and especially Black women, to make the decisions about what they need in their own lives. As a mother myself, I know what it means to parent, and I believe my patients when they tell me that this is the right decision for them. And so if we are really concerned about improving the lives of Black mothers and children, of Indigenous women and children, then I would encourage us to advocate for programs that we know have a clear benefit. We need to be advocating for social support instead of co-opting language around the movement for Black lives in this moment in time. We should be strengthening community supports. We should be addressing over policing. We should be working to decrease violence in our community. The claims, those other claims, are a distraction.
Thank you. Dr. Palacio, for my 24 seconds that are left.
Sure. I have to wholeheartedly endorse Dr. Parrott's comments. And just to sort of set the policy landscape, since 2011, states have enacted more than 450 new abortion restrictions. So let's understand that this is something that's happening with force and emphasis, and that 40% of those restrictions have been, that's 40% of the restrictions since 1973. So Hyde is no accident. Hyde is not just racist, it is part and parcel of a frankly wicked web to try to constrain people's autonomy to make their own choices.
Okay, thank you. Thank you. What I'd like now to do is, and if I'm hoping that our witnesses are all right with us staying, and to my colleagues, what I'd like to do is to do a second round, but do it for just for 3 minutes, and to move as rapidly and as quickly as possible. With that, let me ask you again to follow up on what you were saying, Dr. Parrott. You are the only abortion provider in the hearing today. Is there any misinformation that you would like to clear up for the committee this afternoon?
Absolutely. I think there are a number of things, but one thing that I'll name is really the fact that we are being encouraged and sometimes forced to think about this issue as a binary or a dichotomy, as black or white. And the reality is that it isn't that way. It's not me versus them. It's not pro-choice versus anti-choice. I'm a physician. I'm a provider of healthcare, and my job is to support my patients no matter what. And that includes for folks that are seeking care for abortion services. The patients that I take care of are making thoughtful decisions. They're making informed decisions. They're supported by their families, by their communities. We are providing compassionate care, and I'm providing care in the community that I grew up in.
So the issue about coercion, can you address that at all?
Absolutely. One of our other witnesses mentioned these so-called pregnancy support centers. And what we're actually talking about are crisis pregnancy centers and fake clinics that are designed and strategically placed next to and near abortion facilities to coerce and to mislead folks that are seeking care. I've cared for patients who have mistakenly, accidentally gone into those places and have been held, in a sense, hostage, been unable to leave. They're falsifying themselves as healthcare providers in many cases, and are coercing patients to carry on with the pregnancy that they may or may not want. The concerns around coercion, I think, really come down to what we're doing when we say that we're restricting the ability for people to get the care that they need through our insurance coverage. That is coercive. Deciding that your health care is different than mine because of your inability to pay or your reliance on governmental insurance. That is coercive, because what that means is that you do not have the dignity of choice that someone with a different insurance carrier may have. And so if we are really concerned about coercion for folks that are seeking abortion care, the solution to that is to eliminate the Hyde Amendment and allow folks the ability to make those decisions that they need, that they know that are best for themselves and their family without these unnecessary and burdensome restrictions. I believe every person should have access to compassionate and quality care, and the Hyde Amendment inhibits people's ability to access that care by putting barriers in their place.
Thank you. I will yield back my time. It's about 12 seconds left, and I will yield to the ranking member, Congressman Cole.
Oh, thank you very much, Madam Chair. Just quickly, I stepped off camera, but you were always within earshot. I was trying to get lunch in, but I didn't think anybody should have to watch me eat spaghetti. So I apologize to all, but I did listen to the testimony and I appreciate that. Appreciate my colleague. Question. I guess I have one question here, and it's to get what I think is an important distinction. And look, I have very strong views on this subject. Everybody on the panel does. I respect that. But there's a lot of charges about the Hyde Amendment being racist. I knew Henry Hyde. I served with him. There wasn't a racist bone in his body. You can disagree with the policy. He was very strongly pro-life. And I think you can argue that this has disproportionate impacts on different races or ethnicities. But I think it's pretty hard to argue that it is itself a racist policy or is designed that way. So I guess I would ask each one of our witnesses, and I'd start with, Dr. Palacio, and then work through. Do you think, genuinely think that the Hyde Amendment is designed to be racist? That is, it's designed to be punitive to communities of color and to lower income communities?
Thank you, Congressman, for that question. I think it's an important question in terms of the way that racism is really impactful. So regardless of intent or regardless of what Representative Hyde was thinking at the moment, the impact is clearly racist. And this is what structural and systemic racism is. It's different from a bias of an individual person. It is the cumulative effect of policies that systematically exclude people from opportunity based on their situation in life, which is based on race and ethnicity. The impact is clearly racist.
I just want to give the others an opportunity to, because I only have a minute here, and I appreciate your answer, very clear. Dr. Parrott.
I would echo Dr. Palacio's statement. The intent is irrelevant. The impact is very clear. As a healthcare provider.
But if I could, let me move on to Ms. Williams, because again, I'm down to about 20 seconds.
Absolutely, I would agree with my colleagues. The Hyde Amendment is racist and it is classist, and our inability to respond to the impacts is also racist, and it's long overdue.
Thank you very much. And if I could, Ms. Bennett, do you think the Hyde Amendment is inherently racist?
No, I will never believe that an amendment that has helped save over 2.4 million lives, many of them Black, is racist. I don't think that racists are in the business of trying to preserve Black lives and generations of children that will come after them. It's absolutely ridiculous to claim that the Hyde Amendment is racist.
Thank you very much. I've exhausted my time. Thank you, Madam Chair. I yield back.
Congressman Harris, I don't see you, but are you there?
Yes, I'm here.
Okay, go for it. 3 minutes.
No, thank you very much. Ms. Bennett, could you just elaborate on that? It's 2.4 million lives, and a large portion of those are in fact minorities. Is that correct?
Yes, absolutely. And when we're talking about forced sterilization, we're talking about these things in the hearing today, we have to remember that these things were pushed by Margaret Sanger, that these things were pushed by people that were eugenicists, that were involved in the abortion industry that we have today. And so that is where we see real racism, with 79% of abortion facilities located in lower income minority neighborhoods, preying on Black and brown mothers and their children.
Now, do you personally find it discouraging to the implication that you might be racist because you support the Hyde Amendment?
Honestly, I'm used to it because I've been doing this work for 15 years. And so even when I used to live in Atlanta and we talked about how abortion was disproportionately affecting the Black community, we were called racist because of that. It doesn't matter. I almost died and now I'm alive, and I'm going to speak out for those who have no voice. And I really don't care what people say about me. Even if they say I don't trust Black women, I trust Black women. I love Black women. I am a Black woman. And I've listened to the ones who have told me they've been hurt by abortion. They were pressured to have abortion by their partners, by their parents, by their professors. I listen to them and I care. And I know that abortion hurts women and families, and it's a moral injustice.
So you basically just don't believe the Turnaway Project. You find that there is flaw. I mean, I know there are flaws. Obviously, you know, they have a very low percentage of people actually provided answers, things like that. So your impression dealing in the Black community is that that is a truly flawed study. Is that right?
Yes, over 70% of women didn't even want to participate in that study. Dr. Michael New and the Charlotte Lozer Institute have done many articles debunking that study and how false it is. It does not represent the majority of women in America. In fact, we haven't even heard from women and men also who have been hurt by abortions, because so often their voices are silenced. They're afraid to speak out. They're not willing to maybe shout your abortion as other people are, because they feel sometimes shame and sometimes guilt. And we haven't even really begun to understand the negative impact that abortion has had on the hearts and souls and minds of individuals in our nation. Maybe we never will know.
No, thank you. And I know one of the panelists, somehow disparaged crisis pregnancy centers, which are really volunteers who just want to help pregnant women. And that's disappointing. But I know that, in Baltimore, they tried to drive them out of business. And fortunately, federal courts overturned that. Finally, Madam Chair, I ask unanimous consent that the Family Research Council study on taxpayer funding of abortion and abortion businesses be entered into the record.
So ordered.
Thank you, and I yield back.
Okay. Congresswoman Lee. Can you?
Okay, yes, thank you very much. Let me ask about Roe versus Wade and its impact in terms of denying certain women who don't have access to resources, who are low income, which happen to be women of color, really aren't allowed there to be included actually as part of their constitutional rights to an abortion. While Roe versus Wade, while it granted a legal right to abortion supposedly for everyone, it only ended up for some, because the restrictions on abortion, like the coverage ban, the Hyde Amendment, it has made the ability to access abortion care burdensome, especially for young people, for people of color, indigenous women, as well as queer, trans, and non-binary young people. And so let me just ask any of our panelists about I would say the morality and the ethical questions around having a constitutional right, and yet the Constitution really does not apply to women who can't access their constitutional rights. So they are denied their constitutional rights because they don't have the money or the resources to exercise those. Maybe Ms. Williams, would you like to respond to that? Because we're seeing this now everywhere in Texas, how basically women aren't able to access their constitutional rights to an abortion.
Yes, thank you so much, Representative Lee. I appreciate this question. There is no right without access. And this is something that abortion funds and direct service organizations like me, like the Lilith Fund, and volunteers across the country who are part of over 80 local grassroots abortion funds know very, very well. We work to support people navigate a variety of compounding barriers that prove to us that Roe is simply, it's important, but it is simply not enough. And we do need to work further to ensure that people can access their constitutionally protected right. And a big piece of that must be to repeal Hyde so that everyone can equitably get the care that they need, especially low-income communities of color.
Thank you, Dr. Parent. Could you respond, and then Dr. Palacio, if we have time?
Sure. I would briefly say that I absolutely agree with Amanda. It does us no good to have a right in theory when in actuality folks can't access that care. And so for folks who are really seeking the care that they know that they need, that they know is best for them, then it is our obligation, if we are upholding the Constitution, to provide those benefits in reality for people who are seeking them, not just in theory.
Thank you very much. I think my time is up. Thank you, Madam Chair, again for your leadership and for really ensuring that we have this public hearing so that the public understands what really systemic racism is in our healthcare system. Thank you.
Thank you. Thank you. Yes, Congressman Molinar. There you are. Yeah. Oh, no, I missed. Congressman Molinar, can you hold? I'm sorry, I skipped over Congresswoman Herrera Butler.
Hi, that's all right. I just want to make a couple points. So what I'm hearing is that so that the Hyde Amendment is systemically racist is what I'm hearing in terms of the answers from the physicians on the call. But I believe refusing to cooperate with or pay for the destruction of someone's child is not an action against that person, but for them and their community. 70% of Americans agree with me on this. 60% believe that we should not have taxpayer funding of abortion. In my view, abortion is a failure to serve a woman in need. It capitulates to despair, and it says there's no hope for that woman as a mother, and there's no hope for her child. But when I look at some of the great Black Americans who are radically changing this country for the better, many of whom grew up in poverty, what if their parents had received and believed that message? Who would be making that change today? Supporters of abortion on this meeting should question whether the promotion of abortion itself is structurally racist, since it disproportionately affects people of color and class, and substantially reduces births to women of color to a much greater extent than white women. Planned Parenthood operates the largest chain of abortion centers in the United States and disproportionately locates those centers in or within close walking distance of minority neighborhoods. 10% of Planned Parenthood clinics are in majority Black zip codes. Yet majority Black zip codes make up much less than 10% of zip codes in the United States. To me, this translates to Black lives lost. I don't know how you can see that any other way, especially when the founder of Planned Parenthood was an open supporter of eugenics. This was part of her goal, and we're buying into that right now. And when we talk about risk to women, there are studies, including a specific study of poor women on Medicaid in California. This is a recent study, it was released, showing a much higher death rate for women who have had abortions compared to women who have given birth, especially from suicide. I would ask the people on this call to support a longitudinal study of Planned Parenthood clinics where abortions are provided, of those women's mental health, of their physical health, and an actual study with statistical data that we can all look at and say what's happening to these women's physical health. To pretend that there's no risk, I think the 99% risk-free comment it can't be based in science, and we have to be talking about statistical data here. I really support and am grateful for this. I'm grateful for this hearing. I'm grateful for the opportunity to talk about it. Ms. Bennett, I think you've really elucidated some of the impacts to women of color in this hearing, even though you're the minority witness. You've done a fabulous job of defending the life of minority children, 30% of whom have been aborted in the last number of years. Let's change that trend. I yield back.
Yes, Congresswoman Clark.
Thank you, Madam Chair. This is a question for Dr. Parrott. We know that women's reasons for seeking an abortion are complex and deeply personal, but sometimes they are also a medical necessity. Can you walk us through what happens when a woman who is receiving care through Medicaid needs an abortion due to a medical complication, and how it is to navigate a complex system of often state-imposed restrictions on the life-saving care they need?
Thank you for that question. It's important to understand that that navigating the healthcare system at baseline can be difficult and complicated, regardless of your insurance status. When you add to that an insurance program that puts unnecessary restrictions on the care that you can and cannot access because of government-sponsored funding, then it becomes even more insurmountable to navigate those systems. And for people who are seeking care, what this looks like is depending on where you're living in the country, even your ability to find a provider who can care for you in the way that you need and you deserve can be very challenging and difficult. Amanda talked about the need to travel, the need to find childcare. much less just even the logistics to be able to get in to see that person. We've had a ton of legislation. Dr. Palacio mentioned legislation that's been passed over the last year that's focused on restricting access to abortion care for someone who is living in a complicated situation that is then exacerbated by the need to access abortion care for whatever reason, medical reason or not, medical indication or not. Being able to navigate these systems and structures in the context of your rest of your life is very difficult. Representative Lee mentioned context. For me, all of my work is grounded in understanding that every person's life, every person's story, every person's experience is profoundly different. And while we all may never come to the same agreement on whether or not a person should have the right to parent or not, we must all agree that deciding care for someone else is not our role. This is a decision that should be held by the individual, and by controlling the insurance benefits like the Hyde Amendment, eliminating access to abortion, it does just that. It says we decide for you what you need and what you deserve.
Thank you.
Congressman Molinar.
Thank you, Madam Chair. Ms. Bennett, you mentioned a friend, Destiny, who went to the ER after a Medicaid-funded abortion. Can you tell us more about her story and how that impacted her?
Absolutely. My friend Destiny, she had an abortion at 5 months in Hartford. The abortion providers let her know that she was actually too far along for, based on Connecticut law, but they decided to do it anyway. Supposedly, Connecticut law, although it does pay for abortion, supposedly they're supposed to consider if there's a health issue, but she wasn't asked any questions about her health. As she told me, they just billed the state. After the abortion, she was rushed to the emergency room, and not directly after, but shortly after the abortion, she was rushed to the emergency room, and they found fetal remains inside of her body, which is something that does happen to some women who've had abortion, a botched abortion. There are baby parts that can be left inside of them. And she was in the ER for 3 days, and she really could have died. And if she had died, there would have been no justice for her, because she signed papers and they would have just said, well, that's the risk that goes along with abortion. And unfortunately, that's what happens when women have abortions and they're not familiar with the risk and they sign the papers. If something happens to them afterwards, well, it's on them. It was their choice. I know a woman who was a nurse at Yale in New Haven, and she also volunteered at a pregnancy center that I worked for. And she told me how many times women who'd had abortions at other facilities would then come to the emergency room at Yale later on in the night because they couldn't go back to their abortion provider and they had botched abortions, whether that was a perforated uterus, whether that was a blood clot, or whatever it may be.
Thank you. And Dr. Parrott, I have a question for you. When a pregnant woman comes to see you as her doctor, I'm assuming she is your patient. Do you have any role with the unborn child as your patient, or is that simply a separate than your patient?
So what I would say is that the question is a little bit confusing, and I would say slightly misleading. So when people are coming to me to seek care, if they're seeking obstetric care, if they're seeking reproductive health care services, if they're seeking abortion care, then I take care of certainly the woman that is in front of me. And more importantly, I talk with her about what her desires are for the care.
So just to be clear, if I can interrupt you just a second. So the child really is not your patient. Is that correct?
That's not how medicine works. That's not how the practice of care works in terms of who's my patient and who's not. So what I do is talk with the person about what it is the care is that they're seeking. So for someone who's seeking care, then absolutely I take care of the person that is in front of me then.
Okay. Well, thank you, Madam Chair. I yield back.
Thank you. Congresswoman Frankel.
Unmute. Hello. Okay, thank you. Let me just clear up some things that have been said. First, I want to say hooray for Planned Parenthood for serving so many women and men in underserved communities, and they have served millions of people with things like HIV and testing, birth control, cancer screening, pap tests, pregnancy services, and information. And let me also talk about racism, systemic racism. It differs from racism on an individual level, but has the same roots of evil. Systemic racism arises when that hierarchy and those privileges get baked into the systems and institutions that govern daily life, okay? That's what systemic racism is. Let me ask a question, I think of Ms. Williams, which is about the dangers of pregnancy crisis centers. Can you expand on that, please?
Yes, thank you, Representative, for this question. There are certainly more crisis pregnancy centers or fake clinics than abortion providers in my state of Texas. And we know that they do not provide medically accurate information. We know that they lie to people seeking abortion access, telling them that abortion is not an option. We've had clients who call our hotline tell us that they performed an ultrasound and told them they were farther along and that they were no longer eligible for an abortion in Texas, which was not accurate. And they often use religious ideology to coerce and manipulate people who are faced with making this really emotional decision. So unfortunately, they do prey on the people that are seeking abortion access and ultimately deny them all of their options and can, in many cases, leave them without understanding their rights.
I thank you for that. And I think that's, I know this is for another discussion at another time, Madam Chair, but the gag rule, the domestic gag rule has to go. The international gag rule has to go. We got to clean up a lot of injustice, not only for our women of color and poor women, but for all the women of our country and our world. And with that, Madam Chair, I yield back.
Thank you. Thank you. Congresswoman Watson Coleman.
Thank you very much, Chairwoman. There's a couple things I want to say. Number one is that there was a comment that Congressman Hyde never ever intended this to be discriminatory in nature. Yet the reference that Barbara Lee read clearly says that, well, those who will be affected are those who live in ghettos. May I ask you to think about who typically has been living in economic ghettos? I think it speaks for itself. Secondly, I think that there's no question that this Hyde Amendment has negatively impacted access to healthcare and a right to an abortion, a safe abortion for women. Women make this decision for a variety of reasons. The underlying issue here is the issue of choice, not whether or not you're pro-abortion or pro-life, but do you respect a woman's right to make those decisions? And if she is insured under some federal program, should she not be entitled to the same health care that a very wealthy woman is? And lastly, I'd just like to know if either one of the doctors would like to clarify anything that has been said today, just for the record. Because from my perspective, there have been a number of statistics mentioned and quote unquote facts mentioned that I believe are quite misleading. And with that, I yield back. My question is to either one of the doctors, Dr. Parrott or Dr. Fazio, if there's anything you'd like to clarify.
Yes, thank you so much, Congresswoman. I'll start and allow my colleague to weigh in. There have been a number of misstatements, a number of citations of unreliable data, and a number of misinterpretation of data that has been going on, and including impugning of the Turnaway study in ways that just don't stack up. This is a study that's been published in numerous of very highly regarded peer-reviewed journals. More importantly, I want to say that that what I'd like to clarify is, for me, the issue here today is really about justice, right? The issue has become a debate on abortion, but this is an issue about justice. Abortion should be accessible to people who are poor the same way that it is accessible to people who are wealthy. Abortion should be accessible and affordable to people who are Black, Brown, and Indigenous the same way it is accessible to people who are white. This is clearly about justice. I have heard people say that if we're going to be telling, people that they need to continue their pregnancies, the point is we shouldn't be telling people they need to continue their pregnancies any more than we should tell people they should be terminating their pregnancies. I, as a Black woman, also as an Afro-Latina, as a first-generation daughter of immigrants, I can also say that people need to treat me with respect, that I have agency to make decisions on my own, and I believe that other women, all women, have the same agency.
Yes. Let me just ask now my ranking member, Congressman Cole. We're going to wrap up. If you have any final comments, and then I will make some comments, and then we will bring the hearing to a close.
Well, thank you very much, Madam Chair. And I want to thank all of our witnesses for coming to testify. I want to thank our members for very robust participation. Not surprising on a topic like this, but I think done civilly and professionally, and each person stating their point of view and why in an appropriate way. And I thank all the participants in the discussion, certainly you, Madam Chair, for presiding over it. Let me make a couple of quick points. First, this is not an issue on which we are likely to agree. I think that's evident here. And again, I respect people who have a different point of view than I do on this issue, but my point of view isn't casually arrived at. Early in the hearing, our distinguished, still current chairman of the full committee made the point that she had, I think, presided over or been a leader of a group of pro-choice legislators back when that was a bipartisan group. When I arrived in Congress, being pro-life was very bipartisan as well. There are a lot of pro-life members in the Democratic Party. Now, for whatever reason, we don't have that on either side anymore. I mean, this has become a highly, not just polarized issue, but it falls very strongly along partisan lines. No question about that. And I say that with no disrespect to people that have a different point of view than me. But I do think as legislators, it presents us with a daunting reality. And that reality is, with all due respect to my friends, if this bill requires Republican support, it's not likely to have it in the House, and it's almost certain it's not likely to have it in the Senate if Hyde is removed. Now, we can have the fight, and again, I don't think anybody on this committee on either side of this issue ever shies away from a fight. I have a lot of respect for my colleagues, having been in the trenches with them and sometimes against them, and people here are passionate about what they believe, and that's appropriate. But as the Appropriations Committee, I think our main job is to get the job done, to make sure that we legislate. I think this issue is going to be very difficult. Certainly, obviously, we're not going to do anything on the balance of this Congress, but I think it'll be difficult in the next Congress, given the narrow majorities in the House and the Senate. Again, no matter what happens in Georgia, and given the rules of the Senate. So I just say that to, again, say I respect the opinions of all concerned here, but I feel very strongly about mine as well. And I want to thank, again, all our witnesses. I thought you were all very professional and very fair in presenting your opinion. I particularly want to single out Ms. Bennett. For obvious reasons, I agreed with her with all due respect, and I did more with the other three. But I think it's tough whenever you're in the minority to come forward and lay out your positions. And I thought this was done respectfully, again, by all concerned and professionally. So, Madam Chair, I've never seen you shy away from a fight or a contentious subject, and I took this hearing as being a sign that will be once again a sign of your leadership. But I also end in knowing that we may not agree on everything, but we know how to work together on a lot. We've demonstrated that over the last 5 years. I look forward in finishing that job this year with a little bit of luck. And then going on when you're the full committee chair in the next Congress and working together with you again. But in this area. I just noticed to my friends, I don't expect your opinions to change at all, and I respect that. Please don't expect mine to change at all either, because it won't. With that, Madam Chair, I yield back.
Thank you. First of all, I'm going to thank the ranking member and for your comments, and I too look forward to our wrapping up what we're trying to get done for 2021, and we are on that path, and it's and I think with some with good outcomes. I want to just say a thank you to our witnesses for a really very thoughtful and committed a testimony, and the professional credentials that you bring in your years of experience in these in this very important and critical discussion. I want to thank our members on both sides of the aisle for their commitment, their determination, their years of trying to address this issue. The issue that a couple of things I want to do in terms of setting the record straight, if I can, at the outset, and I want to make just for Planned Parenthood. As of January 2019, 56% of Planned Parenthood health centers were located in health professional shortage areas. That's rural or medically underserved areas. And about 4% of Planned Parenthood health centers that provide abortion services are located in communities where more than 1/3 of the population is African American. Their mission is to build a world in which every person, regardless of race, income, insurance, gender identity, sexual orientation, abilities, or immigration status, can access expert, compassionate sexual and reproductive health care, information, and education without shame and without judgment. I also want to say that I am proud of my state of Connecticut and what they have done to remove barriers in accessing comprehensive health care, which does include abortion, so that people who need it can access it. I would also just say for the record that, in fact, Connecticut has mandatory counseling for those who are under 16 years old. The issue was spoken about in terms of parental notification, but you need to have mandatory counseling in the state of Connecticut. And there's only one point more that I would make in terms of the record, because I heard loud and clear that what are the other services that are critically important to women. And if you take a look at the issues and assistance for housing, childcare, nutrition, we are debating those issues right now. We are looking at housing services and eviction notices that are going to to save a child care industry. And we're losing that battle because, and women are dropping out of the workforce because their kids are at home and are dealing with schooling online, and there are no child care centers. So they are staying home and they're not going back to work. That's the reality. of the services that we speak about, but that are not there for women and for their families. If we could say we were moving in that kind of a direction, maybe we could have some different views on some of these issues, but it's not the case. And I am so grateful for the discussion this morning. And I just say, whatever your views are on the issue of abortion, whatever they are, our public policy decisions and their effect on the people that we represent, that is where our responsibility lies, is what is happening. This is an important issue. It is a sensitive issue, and it is one that we have been reluctant to address. And it is long overdue. It's over 40 years of a Hyde Amendment. You know, in 2015, we had an anti-Hyde hearing. We have not had a conversation about Hyde in this way in decades. In decades. What are we afraid of? What are we afraid of? Nobody's here to question, you know, Henry Hyde's motives or anything else, but look at the consequences that have been discussed here today. And who are the people that these consequences have affected in so many ways? It's women of color, it's communities of color. Our goal as members of Congress is to ensure that women of color and all women have access to the reproductive health care that they deserve, that they need and that they deserve. One has to look at the consequences of the public policy initiatives that we enact and maybe take another look at those consequences and say, is this what we want to do? Is this where we want to go? That is what we need to be addressing. And that policies that fail the test of providing women of color who are most affected by this, that they have access to the reproductive health care that they deserve. That's what our job is. We are in the business of dealing with public policy and its effect on women. And I'll speak for myself that the Hyde Amendment has failed women of color, and communities of color to be able to access the health care and the reproductive health care that they need. And I thank everyone again. I thank us for an open discussion about this. And yes, to my ranking member and my colleague and my friend, I'm not sure that positions will change, views will change, but let's hope again that we can look at some of these effects and how it is that we can change the ability for women and women of color to be able to access that health care. I think the discussion has been very good. It's been thorough, and we will continue to have these discussions. We cannot shy away from what are sensitive issues, but critically important issues as we go forward in doing our job for good public health policies that have led to racial inequities in our society. And I thank everyone, and with that, this hearing is concluded. Thank you very, very much, all of you.